for this opportunity. So in the next 15 minutes, 10 minutes, I think, 15. Okay, my job is to speak about the role of circulating tumor DNA in colorectal cancer. So this slide, I think, is just about the role of circulating DNA in any cancer, and colorectal cancer is not an exception. So if you have a test like this, the potential of this test of circulating tumor DNA can be in screening, which is the clinically undetectable disease. If you can do a blood test and find that there is a potential or a possibility of developing a malignancy later, and that is what I think everybody is looking at. And there are certain companies which have started doing tests for screening for cancer, which are some of these tests are which include colorectal cancer as well, but none of them are approved. Or if you have an early detection in clinically detectable disease, where before a tumor is detected in any other test, if you can detect it by circulating tumor DNA, or we can, in early stage disease, can we do some risk stratification? After surgical resection, can we do sort out patients for treatment versus no treatment, or treatment with some specific protocol versus something else? And also, after in early disease, if you all the patients has gone through the treatments, and now when you are monitoring the patient, can we do residual disease detection and find out relapse much before the actual happens? And in metastatic disease, option of getting the molecular profiling, we just heard about molecular profiling, sidedness. Can we actually do this through liquid biopsy? Can we do response monitoring of when you give treatment, and also resistance mechanism? We are talking about EGFR rechallenge. There is one good paper which has looked at ctDNA based EGFR rechallenge in this. So with this, there can be role in early detection, for tailoring of treatment, for MRD assessment, for monitoring tumor response, and assessing resistance mechanism for clinical trials. And colorectal cancer, there is a wide range of significantly mutated genes affecting multiple signaling pathways, which can be the kinase activity, transcription factor, RNA binding, for so on and so forth. So definitely there is a potential for a ctDNA monitoring in colorectal cancer. Let us come to the point of different phases of colorectal cancer and the role and published evidence. So these are the studies which have looked at clinically undetectable disease. These are all cfDNA based tests actually. There is a cancer-seq test, which is for multiple types of cancer. There is a colon cancer specific test of colo defense. Then there is a pan-seer test, Galleri. All these, it's a crowded slide, purposely kept like that, because it is not, one of them is not showing anything specific than the other. So we can say that there are thousands of samples which have gone into this stage 1 to stage 3 cancers have been looked at. And highest prediction accuracy, that is specificity, of almost 99%. If you get a positive test, the chance of developing having cancer, that positivity is highest for colon cancer, but sensitive. If I have to summarize in clinically undetectable disease, the ctDNA tests are less sensitive. Sensitivity ranges from 70 to 80%, which is not good enough. So sensitivity should be high, specificity should also be high, and there is no such screening test actually. And there is, if you take the methylation, the CEP9 and VIM methylation, the sensitivity pattern increases and specificity already is high. So those are more promising than some of the other tests. Then there is the DNA fragment length was measured in one of the studies called Delphi study. Then combining the DNA fragment length and ctDNA methylation was done in Lunar 2 study. In one line, in clinically undetectable disease, that is in screening or in early stage disease before the other tests come, there is no test which is at present for clinical practice and is still experimental. If somebody is doing a test for colorectal cancer screening by liquid biopsy, then that is not standard. So that is about the clinically undetectable disease. Now, let us go to the curative intent scenarios, that is post-surgical resection, and also in neoadjuvant therapy, which is of lot of interest for us in rectal cancer with especially the dostal data, which actually showed that a large majority of the patients, if they have MSI high, don't need further treatment if they're on immunotherapy. When you have a large majority of rectal cancer patients nowadays getting the total neoadjuvant therapy, whether we can do a liquid biopsy and decide on whether the patient will need surgical treatment or not. So the post-surgery studies are also multiple studies. There are patients from stage 2 to stage 4. That is stage 4 limited disease, oligometastatic, have undergone surgical resection and then decide on ctDNA based decision making. So these are all small studies. Some of them are 20 patients. The largest one has got around 1,500 patients in this. And what we take from all these studies is that there is definitely something to say that if you have a ctDNA positivity after a surgical resection in early stage or in oligometastatic stage, if the ctDNA remains positive, then it is associated with inferior outcome, inferior disease-free survival. So if you see this graph, this is about the prognostic impact of ctDNA. The RFS and DFS rates are lower in patients who have a detectable ctDNA, and overall survival is reduced who have detectable KRAS mutations in the ctDNA. So definitely we can do a non-invasive disease monitoring and molecular tracking of CRC, which may help in what do we do with these patients post-surgery, post-curative intent surgery and chemotherapy. If you have a ctDNA positivity, are we going to treat them? That question is unanswered. But if you have a ctDNA monitoring, we can say that these patients are going to do bad and maybe needs more stringent surveillance. Similarly, post-operative ctDNA status is predictive of survival. If you have MRD positive patients who were 14 in 152, 78.5% of these patients relapsed. That is pretty strong prediction. So if you have an MRD positivity after curative intent treatment in early stage colorectal cancer, if the ctDNA is positive, the chance of recurrence is almost 80%. I don't think any other test can predict this strongly about the chance of recurrence in colorectal cancer. And post-adjuvant therapy, the ctDNA negative patients do well than the ctDNA positive patients. From this, there is only one study which actually has looked at something clinically significant for us, which is the stage 2 colorectal cancer patients. Because in stage 2, now it has become very complicated about treatment decision making. All the patients may not benefit with adjuvant therapy. Of those, all the patients may not benefit with 5FU and oxaliplatin based therapy, the MSI high versus MSI low. So this study, which actually, this is a NEJM publication for in stage 2 colorectal cancer, which was the dynamic study actually. This looked at 455 patients. 302 were assigned to ctDNA guided management, which is 2:1 randomization. 153 went through the standard management. The median follow-up was 3 years. The ctDNA guided group actually received the less number of them. So if the patient had ctDNA negative, they did not get chemotherapy. And 15% or only 15% of the patients who had ctDNA negative got chemotherapy, whereas the other group, 28%. So half of we could reduce the patients who get adjuvant chemotherapy by half if you go by a ctDNA based therapy. Still, there was no difference in outcome. The ctDNA guided management is non-inferior to standard management. 93.5 versus 92.5 and 2.4%, which is not statistically significant. So 3-year recurrence-free survival is 86.4 for patients with ctDNA positive, regardless of whether they got chemotherapy or not, and 92.5 if they are ctDNA negative. So this study is a significant study, which tells us that probably just like what we do in breast cancer, if you can sort out patients based on the risk stratification, we can do that in stage 2 colon cancer by doing a ctDNA analysis And if the ctDNA is negative post-surgery, regardless of what is the other parameters of the patient, we can actually opt for a no chemotherapy-based surveillance. And this is one study which I think can be practice changing as of now. Regarding the neoadjuvant data on rectal cancer, there is similar data which is available for colon cancer. Most of the data in rectal cancer, what we have in any situation is an extrapolation from the colon cancer data. And that is not, that is similar about the ctDNA in rectal cancer. So the 72 patients who underwent a total neoadjuvant therapy, the pre-surgery ctDNA detected MRD in 15%, they were statistically associated with shorter DFS and OS. There is an ongoing study which is prospectively investigating the role of ctDNA in defining adjuvant approach after total neoadjuvant therapy. So to summarize, in rectal cancer, we can't take a treatment decision of no surgery versus surgery based on ctDNA as of now. I know that the TNT approach has actually taken lot of patients are now trying to ask us, or even oncologists are thinking whether we can avoid surgery in some patients with rectal cancer. And Vikas is here. I think he's one of the biggest proponent of TNT in rectal cancer. I don't know whether we can take a decision based on liquid biopsy at this point of time. And similarly in oligometastatic disease, as I said, this is from the data. The patients who have undergone a curative intent surgery with the oligometastatic disease, the ctDNA is predictive of outcome. So MRD negativity during serial ctDNA sampling was also associated with the significantly better patient outcomes. Now, this is another maybe practice changing study based on ctDNA. We were just discussing that before I started the talk. So this study actually even challenges the way we look at cancer therapy, according to me. Now, the way this has been discussed recently in many of the forums, I have started thinking whether we should actually give bevacizumab in first line for any patient of metastatic colon cancer, if this is the way the clonal evolution happens. So this is the Chrono study, which looked at EGFR rechallenge. So these are the patients who are started on anti-EGFR therapy in first line. And we can see that the EGFR, after some time of giving EGFR, the patient develops, and giving anti-EGFR therapy, the patient develops resistance to that. And the resistance mechanism is by developing KRAS mutation. Now the patient gets a drug-free interval, or the patient goes off anti-EGFR therapy for a period of time. And the KRAS in the ctDNA actually has come down, and the patient becomes KRAS wild. And these patients are challenged with single agent panitumumab. So patients at baseline were have been KRAS positive, KRAS mutant patients, getting a response because they have got a anti-EGFR free time for some time, and getting single agent panitumumab. In this study, the response rates were 33%, and stable disease was around 60%, if I am not wrong. So that is amazing. And this is a study which was based on ctDNA monitoring. Yeah, this is the study actually. The primary endpoint was objective response rate. Secondary endpoints were PFS, overall survival, safety, and tolerability. So the patients with RAS wild type tumors, after a previous treatment with anti-EGFR regimes, underwent an interventional ctDNA based screening. 30% partial response, 63% disease control. So this is amazing, and that is why this small study gets into Nature Medicine, if you see. So coming back to the previous graph of whether where all we can use ctDNA based test, let us see. This is my concluding slide. In cancer screening and early detection, there is limited data as of now. In early stage risk stratification, definitely there is data. We may use it immediately in patients who are stage 2, whom we want to avoid chemotherapy. In early stage neoadjuvant in rectum, limited data, but encouraging data. We can, especially if a patient wants to avoid surgery, we may use this, but it is not standard at this point of time. In MRD monitoring, limited data in late stage, and definitely in clonal dynamics, as I said in this study, this is interesting. Now, my last, because Dr. Govindababu sir was asking in the other hall about the ChatGPT. So I took 3 days. I mean, not full 3 days, but I
different times of 3 days to prepare this talk. And I just put in chat GPT just before, and this is what it gives actually. This is 30 seconds. Okay. If I had waited for some time, it would have give it populates if you have used it. So the chat GPT gives similar kind of a conclusion slide in 30 seconds. So I think we can all